A warm good afternoon to each and everyone present here. Today's topic is diagnosis and treatment planning in fixed partial dentures. I have basically prepared this presentation as a 20-mark question. So we will cover what all we have to write about and what all we have to cover and what we have to mention in our exam papers, right? So this presentation is purely made from a point of view of examination. Okay, so let's go. Dividing this entire topic into two portions, diagnosis and treatment plan. Diagnosis will see about introduction, history, the chief complaints, medical history, dental history, general examination, that is extraoral examination, intraoral examination, and finally the diagnostic aids. In treatment plan, we'll be covering about treatment planning for single tooth restorations and treatment planning for missing teeth. So under diagnosis, we'll be speaking. Basically, diagnosis is the process of identifying a disease or a health condition by analyzing the patient's signs, symptoms, and other relevant facts to arrive at a specific name for the ailment. So that is basically what diagnosis means. Treatment plan is nothing but it's a subsequent process of developing a stepwise strategy or a plan to address the identified problems to work towards a desired long-term outcome, taking into account the patient's interest and any circumstances that might affect the treatment's success. We have four important elements in diagnosis, that is the history, the extraoral examination, the intraoral examination, and the diagnostic aids. In history, we cover about the demographic data, the chief complaint of the patient, the medical history, and the dental history. In demographic data, we generally record the age, gender, family status, occupational history, income about the patient. This is and also including the concerning reasons for seeking the treatment along with any personal information and including relevant previous dental as well as medical experiences. In chief complaint, we generally record the chief complaint based on four basic types, that is the comfort, social, function, and the appearance. In comfort, we generally record pain, that is the location, the character of the pain, the severity, the frequency, whether there are any factors which precipitate this pain, if it is localized or diffused in nature, and sometimes it will be helpful in diagnosis if the patient pinpoints to an area or a point where the pain starts. We also note down about swelling, that is its locations, the size, the consistency, and the color, and whether if any hot fermentation or anything was given which resulted in increase or decrease in the swelling. So under social, we usually record any reporting of bad taste or odor from the patient. We also check whether it is due to some periodontal disease or just due to some compromised oral hygiene. We generally record, are there any difficulties in chewing for the patient? Is there any fractured cusp or missing teeth? Is there attrition if present, whether it's localized or generalized? And we also note down any malfunction or dysfunction that is present. Appearance, we note down information about missing teeth, fractured teeth, fractured restoration, any crowded teeth present, are there any unattractively shaped teeth, are there any malpositioned teeth or any discolored teeth that are present. In medical history, generally the medications taken by the patient and relevant medical conditions are noted down. If in certain cases required, then we can contact the physicians of the patient for further information. So basically, we divide this medical history into four broad classes. The first one contains of conditions affecting the treatment methodology, which generally include any disorders that necessitate the use of antibiotic premedications. any use of steroids or anticoagulants, any previous allergic responses to medications or dental materials. The conditions affecting the treatment plan, that is any previous history of radiation therapy, any history of hemorrhagic diseases, the extremes of age, that are at extremely young age or extreme old age, and terminal illnesses. Under systemic conditions with oral manifestations, many conditions present periodontitis, which may be modified by diabetes, menopause, pregnancy, or any use of anticonvulsant drugs. In case of high shell hernia, bulimia, and anorexia nervosa, the teeth may be eroded due to regurgitated stomach acid. Certain drugs also generate side effects and mimic TMDs and reduce salivary flows in nature. And the fourth and the last is the possible risk factors to the dentist and the auxiliary personnel. Patients who are suspected or confirmed carriers of hepatitis B, acquired immunodeficiency syndrome, or syphilis are to be careful. Of course, in current scenario, corona was also added to the list. So coming to the dental history part of our examination. In dental history, we divide it into pertaining to departments so it becomes easy for our diagnosis. So first what we record is the oral surgical history, that is under which we record the information about any missing teeth, any complications that may have occurred during tooth removal or bony or soft tissue corrections as well as removal of it. The periodontal history is basically assessed for the current plaque and calculus status and what were the measures that are discussed, and any previous instructions were received by the patient for oral hygiene maintenance. The frequency of any previous debridements or any cleanings underwent should be recorded. Restorative history, it is important to record about simple composite restorations or amalgam fillings or any other fillings that are done, or any extensive restorations like fixed partial dentures which are present. The age of the existing or the previous restorations done would give us a probable longevity of our future fixed prostheses. Occlusal adjustment also should be recorded, whether the patient has undergone before or requires any occlusal adjustment before going ahead for a fixed prosthodontic therapy. Down the endodontic history, the periodic checkup of the perioapical health of an endodontically treated teeth should be monitored, and any recurring lesions should be promptly detected. Generally, the defective endodontics may lead to recurrence of periapical region and retreatment would be required. While considering the orthodontic history, as the crown root ratio is affected during the orthodontic treatment, the future prosthodontic treatment and its prognosis may also be affected. Generally, restorative treatment can often be simplified by minor tooth corrections or totally avoided just by doing a tooth movement. So orthodontic treatment should be incorporated into the treatment plan. Generally, in radiographic history, we also take the note down any previous radiographs that are been taken for assessment of the treatment or assessment of the bony levels, and they should be obtained possible. It is generally better to avoid exposing patient to unnecessary ionizing radiations. Of course, in most instances, the current radiograph would be helpful, but a previous radiograph would give you an insight about the bone and the teeth health that is present over a period of time. We also record the temporomandibular joint dysfunction history, whether there was any history of pain or clicking in the joint or any neuromuscular tenderness which was elicited on palpation, which may be due to TMJ function, but normally be tested and should be normally be tested and resolved before going ahead with the fixed prosthodontic treatment. We move on to the extraoral examination. Under extraoral examination, first we start with a general examination where we assess the gait of the patient, the general appearance of the patient, the skin color for any signs of any diseases, And we also record the vital signs of the patient to record the vital signs such as the respiration rate, the pulse, the temperature and the blood pressure are to be measured and recorded. Under aesthetic evaluation, we evaluate the vertical and transverse facial morphology, the facial profile of the patient, the facial proportions that are present between the upper and the lower portions of the face to identify any adverse growth patterns. And we also measure the upper lip to lower lip height ratio. The facial symmetry is to be noted down. We should also note down the development, tonicity and form of the facial muscles and the soft tissue present. The nose size and proportion and symmetry to the rest of facial structures is recorded in cases of aesthetic or anterior fixed partial dentures. Similarly, we also record the chin size, that is its shape, symmetry and position related to the other facial features. The lip component, that is the size, the tonicity and the position with respect to the incisors is also noted during the rest as well as in the function. We also note down the intensity and the depth of the nasolabial sulci, the mentolabial sulci, and we also note down the patient's posture of the head. Under TMJ evaluation, we basically place our index, middle and the ring finger over the temporomandibular joint and ask the patient to open and close, and we approximate the movement of the joints, whether they are synchronous or asynchronous in nature. Usually asynchronous movements are detected when there are anterior disc displacements, and the auricular palpation with light anterior pressure will help in identifying potential disorders of the posterior attachment of the articular disc. Any pain or tenderness on palpation is noted down in each of the joints, and also the mouth opening is assessed whether the patient has an adequate, average or a restricted mouth opening. Also during this procedure we assess whether there is any midline deviation during opening of the jaw or closure of the jaw. We also assess the muscles of the mastication by bilaterally and simultaneous palpation with light pressure. We generally note down the tenderness or any pain or discomfort that is present in mild, moderate and severe format. So basically we palpate the muscles of the mastication, that's the masseter, temporalis, lateral pterygoid and the medial pterygoid, and also the muscles, accessory muscles, that are the sternocleidomastoid, the trapezius and the digastric group of muscles. Now coming to the intraoral examination. Under intraoral examination, first we assess the teeth, that is the DMFR status, that is any missing or present teeth that are recorded, any teeth which are decayed, teeth which are restored, type of restoration, and teeth which are filled. During assessment of the gingiva should be generally lightly dried before, so that any moisture or saliva present should not obscure the quality of the gingiva. So basically here we note down the color, the texture, the size, contour and the consistency as well as the position relative to the teeth is noted down. The gingiva is generally palpated with light pressure to see any presence of exodus or pus present. While noting down the changes in the periodontium, generally we use a periodontal probe or a mark probe which is present to assess the depth of the pockets that are present, or to mention that whether the gingiva is healthy or no on all surfaces of the teeth. So generally a probe is taken parallel to the long axis of the teeth, which we generally say call the term as walked through the gingival sulcus. Under periodontium, we also note down the following characteristics, that is the tooth mobility or malpositioning, any open or deficient contact that is present between the teeth, areas of inconsistent marginal heights, areas of inadequate attached keratinized gingiva. If there are any furcations involved are to be noted down, and any malpositional frenal attachments or extra frenal attachments that are present. In intraoral examination, we also assess the occlusal status of the patient. Here, basically, the objective is to determine what extent the patient's occlusal differs from normal and how well the patient has adapted to the difference. So basically, with this, we record this occlusal status of the patient into 4 different categories. That is the initial tooth contact, the tooth alignment that is present in the patient, eccentric contacts, and jaw maneuverability. So coming to the initial tooth contact, here basically the patient is guided into a terminal hinge closure to detect where the initial point of tooth contact occurs. The clinician should basically ask the patient to close feather light and stop whenever even a single teeth or a portion touches, and has been recorded and noted down. We also notice during this initial tooth contact, we ask the patient to close further, where we notice any presence of slide from the centric relation to the maximum intercuspation, which is to be recorded. So the presence, the detection, and estimated magnitude of the slide should be noted down, and any such discrepancy in CR or MI should be evaluated and should be assessed with signs and symptoms generally associated with them. Under tooth alignment, we evaluate for teeth any presence of crowding, rotation, supraeruption of opposing teeth, spacing present between the teeth, the malocclusion, and vertical and horizontal overlap. We also notice any presence of tip teeth that are present, supraerupted teeth, and drifted teeth, which may affect the outcome or the decision of treatment planning in the fixed partial treatment. Under eccentric contacts, we generally ask the patient to do exersive contacts, and we also see the protrusive contacts which may be desirable and undesirable in some areas. Like in protrusive contacts, you do not want any contact in the posterior teeth that is present, and we also assess for patient's occlusion, whether the patient has adequate amount of disocclusion during eccentric movements, or the patient or in what occlusion the patient is currently in, whether it is in a group function or a mutually protected occlusion or a canine guided occlusion. The jaw maneuverability, we just assess the patient's ease and the access of the patient to open and close mounts and move the jaw in right, left, and protrusive directions. This generally indicate the patient's oral musculature, the muscles of mastications, and the joint health. So now we come to the last portion, that is the diagnostic aids. Under diagnostic aids, the most commonly used is the radiograph. Of course, it gives essential information to supplement our clinical examination and arrive at a diagnosis. A detailed knowledge of the extent of bone support and the root morphology is present in the radiograph. The use of digital radiography reduces the radiation exposure. The most information with a minimal need for repeated films can be done using digital radiography. There are different types of radiographs which we assess where we assess the presence or absence of teeth, assessing the presence of third molars or any impacted teeth that are present, evaluating the bone before and after implant placement or the adequacy of a bone for implant placement, and for screening of edentulous arches to see for any buried or residual root tips or teeth present inside. So generally we have different types. Those are the intraoral periapical radiograph, the orthopantomograph, the cone beam CT, and the lateral SEPs, which are generally used in fixed partial treatment planning. Special radiographs like lateral cephalogram and CBCT are required for specialized treatment like planning of implants, whereas lateral cephalograms and CBCTs both we use it in assessment of airway analysis of the particular patient. It is very useful to assess the vitality of a particular teeth which will be used as an abutment for the fixed partial treatment before any restorative treatment is done. Basically, we measure the vitality by its response to either percussion, the thermal or electrical stimulation, which would guide us for any precluding endodontic therapy required for the fixed partial dental treatment. We also record the bite force in patients to assess whether their bite force is normal or excessive. Basically, this will help us to decide the choice of the material and type of restoration to be given to for a particular patient. We also make diagnostic casts for the patients because these basically they permit us to do static and dynamic movements without the interference of the oral musculature, and of course it gives an unobstructed view from all angles including from the lingual side. So after recording all the details of a particular patient, we generally correlate it with different conditions in which these signs or symptoms may be seen. So basically what we are doing is we are doing a differential diagnosis to eliminate all other ailments and reduce it down to one to arrive at something called as a definitive diagnosis. Basically, your definitive diagnosis is a condensed information after eliminating other ailments from your differential diagnosis and arrive at a particular point. There may be in some conditions where there may not be any signs of symptoms like in presence of patient of occlusal dysfunction or orofacial pain. Therefore, a logical and a systematic approach to diagnosis will help avoid mistakes. Also note down the provisional prognosis of the treatment that we will be rendering to the patient based on the age of the patient, the lowered resistance of the oral environment, the general factors including the medical and the dental, the forces applied on given teeth, the access to oral hygiene measures by the patient, and the local factors that are present in the patient's oral cavity. Coming to treatment planning, so basically what we are doing here is we are assessing whether the patient requires an extensive coverage of the damaged teeth to be restored using different types of material based on the diagnosis and the history that we have recorded from the patient, which will help us in giving a good prognosis for our fixed partial denture treatment. The factors that we consider in the type of tooth restoration is basically divided into four portions. The first is based on the destruction of tooth structure. So basically the amount of tooth structure decides whether you are going to give an intracoronal or an extracoronal type of restoration. Of course, aesthetics plays a prime important factor in this. Whether the patient is going to be, whether it's going to be cemented into an anterior or a highly visible area, considering of various different options, whether you can go in for veneers or partial coverages crown only for aesthetics as a concept. The other factors that we consider is the plaque control, where the restorations demands a good plaque control by or oral hygiene maintenance by the patient. So we need to take this factor into account. Of course, the main important factor that we see in a particular teeth is the amount of retention. Usually the full coverage crowns are most retentive, but also involve extensive cutting of the tooth structure. Of course, the maximum retention is not nearly important in single teeth restoration as it is for your fixed partial denture retainers or restorations with any missing teeth present. And last but not the least, the finances of the patient may also dictate the change in the treatment plan or the material that you have chosen for the particular treatment. So the tooth restorations can be broadly classified as intracoronal restorations and extracoronal restorations. Intraoral restorations are considered when there is sufficient amount of coronal tooth structure that exists which can retain and protect the restoration under the anticipated stress of the restoration. So here basically the crown of the tooth as well as the restoration itself is dependent on the strength and integrity of the remaining tooth structure that is present. The examples are inlays and different onlays depending on the coverage of the particular tooth structure. Extraoral restorations are considered when there is insufficient amount of crown structure that is existing to retain the crown completely. Hence, a complete extracoronal restoration is planned. It is also used where there's extensive areas of defective axial teeth structure and there is a need to modify contours in occlusion or improve aesthetics in particular cases. Examples are full crowns which cover your metal, PFM and ceramic crowns, and crowns which extend into the radicular portion, those are the endocrown. Coming to treatment planning strategies with missing teeth present. Of course, in anterior teeth, the patient is more concerned about aesthetics, whereas in posterior teeth, it is equally important as it gives optimum function. Of course, it is tempting for us to think the oral cavity as a static entity. Of course, we make many of the crowns with a static relationship in articulators, whereas the dynamic of the patient's oral cavity dictates its own terms. A particular tooth is lost, of course, the structural integrity of it is also lost with it. In the dental arch, there might be a subsequent realignment of the teeth. That is, posterior or anterior teeth may move into the space or opposing teeth move into the existing edentulous area. So we have different options for fixed partial dentures with missing teeth. Generally, the most considered is the conventional tooth-supported fixed partial dentures, the configuration of which generally consists of two abutment teeth with a single missing edentulous area in between. The factors that govern the treatment of conventional tooth-supported fixed partial dentures are basically depends on the uh, quality of the teeth which are present to be used as the abutments, the retainer designs that is to be used in a particular patient. We should also assess that there is no gross soft tissue defect in the edentulous ridge. If there is, we may go in for different graft treatments, and it would be both reserved for patients who are highly motivated and able to afford the surgical procedures. Generally, we also notice about the dry mouth, which creates a poor environment for any crown. The margins of the retainers will be at great risk from the recurrent caries, which will limit the lifespan of the fixed partial denture treatment. Resin bonded tooth support fixed partial dentures are a convenient option as they are more conservative in nature. Generally, there is a situation where there is a single missing teeth, either an incisor or a premolar. A molar can be replaced with this type of processes if the patient's muscles of mastications are not too well developed, thus assuring that the minimum load will be placed on the retainers. But ideally, they are given in only lower incisal regions or upper lateral incisor regions where the force is least dictated in our oral cavity. Implant set supported fixed partial dentures are a great choice, particularly in patients where there's missing abutment teeth or there is too long span or there is an inadequate strength present in the abutment teeth that can support a conventional fixed partial denture treatments or any intraoral factors or patient considerations which do not let you use RPD as an option. So implant supported fixed partial dentures can be used in replacement of teeth either in a single missing teeth directly or in a long span as a bridge which is limited only by the bone available and not by the presence of the teeth or the status of the teeth that are present. The last is that no prosthetic treatment. Of course, if the patient presents with long-standing edentulous space where there has been little or no differing or elongation of adjacent or opposing teeth into that area, the question of replacement should be left to the patient's wishes. If the patient perceives no functional, occlusal or aesthetic impairment, it would be dubious service to place a prosthesis in such cases. So coming to the basic treatment planning of tooth supported fixed partial dentures, you need to be careful in selection of the abutment teeth for your fixed partial dentures. Of course, abutment selection of the teeth is a different full question, but you need to mention in brief during your diagnosis and treatment planning of fixed partial dentures. So here in abutment selection, the restoration, we select the abutment so that the restoration must be able to withstand the constant occlusal forces. This is of particular significance when designing a fixed partial denture. The forces would normally be absorbed by the missing teeth or transmitted through the pontic and the connectors and retainers to the underlying abutment teeth. So if a tooth adjacent to the edentulous space requires a crown because of damage to the tooth, the restoration can usually be doubled up as an FPD retainers also. Of course, and in several abutments in one arch require crowns, then there is a strong argument for selection between a fixed partial denture and a removable partial denture. Whenever possible, an abutment tooth should be a vital tooth. Of course, if it is endodontically treated, you need to be sure about the endodontic obturation as well as seal that is provided by the endodontic treatment for the success of your treatment. In certain cases where there is extensive loss of coronal teeth structures, the use of post and core or the dowel core or a pin retained amalgam or composite resin core can be considered as a treatment option before converting it into an abutment. The teeth that have been pulp capped in the process of preparation should not be used as an FPD abutments unless they are completely endodontically treated. While considering abutment selection, we always assess that the abutment teeth should not exhibit mobility because they will be carrying the extra load of the missing teeth as well. The roots and the supporting tissues are basically evaluated for the crown root ratio, the root configuration, and the periodontal ligament area, which is dictated by the Antis law. Coming to treatment planning, where there are more than one missing teeth present, here the most common examples being generally given is canine to second molar FPDs. They are possible in more in maximal maxillary arch when the conditions of course are ideal, but not as often in a mandibular arch. Basically, they present biomechanical failures which play an important role. The failures are basically due to abnormal stresses that have been attributed to leverage and torque rather than overload of the bite force. The abutment teeth can be maintained free of inflammation in the face of mobility if patients are well motivated and highly proficient in oral hygiene maintenance. In addition to the increased load that is applied on the periodontal ligament by long span fixed partial dentures, they are less rigid in nature. Bending or deflection of the material generally occurs with the cube of the length and is inversional with the cube of the occlusal gingival thickness of the pontics. The longer pontic spans also have a potential for producing more torquing forces on the fixed partial denture, especially on a weaker abutment. So basically in long span bridges, the deflections will be 8 times if the span is doubled from single to 2. So the considerations that we need to take into account is to minimize flexing is that the pontic designs with a greater occlusal gingival dimension should be selected, and the prosthesis may be also fabricated with an alloy with a higher yield strength such as nickel chromium. Secondary abutments or double abutments are sometimes used as a means of overcoming problems created by unfavorable crown root ratios and certain long span cases. Here basically the root surface area and as favorable crown root ratio as the primary abutment is intended to bolster. So the retailers on the secondary abutment must be as least retentive as the areas on the primary abutment, as when the pontic flexes they will apply more tensile forces on the secondary abutment that is present. So sufficient amount of crown length and space between the adjacent abutments should be considered to prevent any impingement on the gingiva under the connector area between the primary and the secondary abutment. The arch curvature plays a crucial role in designing of fixed partial dentures. So basically when the pontics lie outside the interabutmental axis line, the pontics acts as a lever arm which can produce a torquing movement. This is a common problem in replacing all four maxillary or mandibular incisors with a fixed partial denture. It will be best accomplished by gaining additional retention in opposite direction from a lever arm and at a distance from the interabutment axis equal to the length of the lever arm. Like the first premolars sometimes are used as secondary abutments for a maxillary 4 pontic canine to canine fixed partial dentures. Because of the tensile forces that will be applied on the premolar retainers, they must have excellent retention. The secondary retention must be extended a distance from the primary interabutment axis equal to the distance from the pontic lever arm that extends in the opposite direction. Coming to special problems that we encounter generally during our diagnosis or treatment planning. One such thing is called as a pyre abutment, where there's an edentulous space adjacent to the abutment teeth on both the sides, on the mesial as well as the distal side. Here generally a long span bridge with a fixed with a rigid connector generally applies tremendous forces on the pyre abutment, weakening it and reducing the prognosis of the treatment. Hence, a non-rigid connector is generally indicated in such cases. The retention a non-rigid connector is generally used when the retention on an anterior teeth is usually less than that of a posterior tooth because of its generally smaller dimensions. Because there are limits to increasing a retainer's capacity to withstand displacing forces, some means must be used to neutralize the effects of those forces. The use of non-rigid connectors has been recommended to reduce this particular hazard. Coming to tilted molar abutments, a problem which occurs with some frequency in mandibular second molar abutment that has mesially tilted into a space formerly occupied by a first premolar. It is impossible to prepare the abutment teeth for a fixed partial denture along the long axis of the respective teeth and achieve a common path of insertion. Cases, if third molar is present, there is further complications. Usually, they would have drifted together with the second molar. The problem is during placing the insertion of a fixed partial denture, the mesial surface of the third molar will cause an interference in seating of the fixed partial denture. Telescopic crowns are basically dual crowns which alter the path of insertion of fixed partial dentures. These generally crowns can be used on the retainers of the distal abutments. Here a full crown preparation with a heavy reduction is made to follow the long axis of the tilted molar with respect to the axis of the premolar. So the inner coping is made to fit the tooth preparation and the proximal half crown that will serve as a retainer for the fixed partial denture that will be fitted over the coping. It basically allows for the total coverage of the clinical crown while compensating for the discrepancy between the path of insertion of the abutments. Here the marginal adaptation is completely given by the coping and is indicated where there is extensive facial or lingual restorations on tilted molar would call for use of this type of restoration. With telescopic crowns, non-rigid connectors can be used in areas indicated other than pyre abutments also. like in areas where the teeth having a present post and core or a double core with some sort of extensive restoration that is present to cover the coronal tooth structure. Canine replacement fixed partial dentures generally pose quite amount of problem, as the usual abutments are the lateral incisors, which are the weakest among the anteriors, and the distal abutments are your first premolars, which are the weakest among your posterior tooth. So an FPD replacing a maxillary canine is subjected to more stresses than replacing a mandibular canine, because the forces are basically transmitted outward, that is labially on the maxillary arch, against the inside of the curve, that is its weakest point. So while considering this canine replacement FPDs, you need to make sure that the FPD replacing a canine should be considered as a complex type of fixed partial denture, and no FPD replacing a canine should replace more than one additional teeth. So FPD replacing maxillary canine is of course more difficult when compared to your mandibular canine. Coming to cantilever fixed partial dentures, these are basically fixed partial dentures which have abutments only on one end, and the pontic is attached to that retainer. This is basically potentially a destructive design with the lever arm created by the pontic and is frequently misused. Generally, cantilever FPDs should replace only one teeth and have at least two abutments, and is given in areas where there are least amount of forces present in oral cavity. The considerations for which are lengthy root with favorable configuration. Ideal would be long clinical crowns. The abutment teeth should have a good crown to root ratio, a healthy periodontium, and there should be no occlusal contact on the pontic either in centric or in lateral or eccentric movements. So coming to the summary, we have seen in diagnosis about the introduction, the history, chief complaints, medical history, the dental history, general examination or extraoral examination, intraoral examination, and diagnostic aids. And in treatment planning, we have seen about single tooth restorations, missing teeth restorations, and special considerations taken into an account. Thank you for your patientful listening.